Welcome to the Explainer. Today we're breaking down clinical humidifiers so you can nail that perfect 10-mark exam score.
So, what happens if we just use dry oxygen? Well, the physiological stakes are actually incredibly high.
Okay, let's dive in. Dry oxygen is kind of like a clinical villain, causing heat loss, thick secretions, and airway obstruction.
Here's our quick roadmap. We'll hit the when, the taxonomy, and deep dive into both active and passive systems.
When do we intervene? Always for oxygen flows, over 4 liters per minute, invasive ventilation, tracheostomies, and chest infections.
Now, let's look at the taxonomy. Basically, active systems need external power, while passive ones run entirely on patient exhalation.
Active humidifiers literally pump moisture directly into the gas flow using an external heat and water source.
Interestingly, we can actually slice these active systems down even further, based purely on their flow and heating capabilities.
And this brilliantly illustrates those mechanics in action. See those variable external heaters hooked right up to the water reservoirs?
But watch out, there are hazards. Without strict monitoring, active systems risk severe thermal burns and nasty Pseudomonas growth.
Because warm, moist environments breed bugs like crazy. Protocol demands swapping out active humidifiers every 24 hours. No exceptions.
Moving on to passive systems, we have heat-moisture exchangers, or HMEs. Think of them as a highly efficient artificial nose.
These compact filters are incredibly cost-effective. They do an awesome job maintaining a ventilated patient's natural physiological air conditioning.
But here's the catch. HMEs are actually the biggest source of contaminated moisture sitting right there in the breathing circuit.
Because of that direct exposure risk, safety protocols strictly dictate changing out those HMEs every 12 to 24 hours. All right, time for a rapid-fire exam wrap-up. First question, what are the common complications of dry oxygen therapy?
Lock these in. Heat loss, dry mucosa, thick secretions, airway obstruction, and totally severe bronchoconstriction in asthmatics.
Next up for review, can you quickly explain the exact clinical difference between active and passive humidifiers?
So, the crucial point is, active needs external water and heat, while passive just recycles the patient's own exhalations.
Last review question for those final exam points. Exactly how often should active humidifier systems be swapped out?
The absolute golden rule. Every 24 hours to prevent dangerous microorganism breeding right there in your clinical circuits.
Knowing all this, ask yourself, are you strictly monitoring your clinical humidification protocols to actually prevent nosocomial infections?